What was early infection control like for CF? Imagine a time when doctors knew little about how infections spread among cystic fibrosis patients. Early practices were often limited and not very effective by today's standards. Before the 1980s, infection control was still developing, and many methods unintentionally increased risks. For example, mist tents were used in the 1960s and 1970s to help humidify the air and loosen mucus. While they helped with breathing, the water droplets in the mist could carry bacteria, and patients could breathe in bacteria from others. This meant that mist tents sometimes helped bacteria spread between patients, which was a big concern. These tents were eventually phased out by the early 1980s once the risks were better understood. In the 1950s and 1960s, antibiotics like penicillin and sulfonamides were used to treat respiratory infections. But these treatments were often not targeted or effective against the chronic infections common in cystic fibrosis. Physiotherapy techniques, such as postural drainage, were introduced to help clear mucus from the lungs. These methods involved tilting patients to drain mucus, but they did not focus on preventing infections. Instead, they aimed to improve breathing and mucus clearance. A major breakthrough came in the early 1980s when researchers discovered that certain bacteria, especially Burkholderia cepacia complex, could be transmitted directly from one patient to another. Before this discovery, it was believed that cystic fibrosis patients did not spread bacteria among themselves. Once it was confirmed that bacteria could be passed between patients, clinics began to change how they managed infection control. They started separating patients infected with Burkholderia cepacia from others, a practice called cohorting. This separation significantly reduced new infections and became a key part of infection control. Other early measures included teaching patients to contain their respiratory secretions and maintain physical distance from other cystic fibrosis patients. Many clinics recommended keeping at least 3 feet apart to reduce the chance of bacteria spreading. Masks were also introduced as a barrier to prevent droplet transmission, although evidence about how effective they were against specific bacteria like Pseudomonas aeruginosa is limited. Overall, early infection control in cystic fibrosis was a gradual process. It moved from minimal and sometimes counterproductive practices to more organized strategies focused on preventing cross-infection. These efforts included patient segregation, hygiene education, and environmental controls. These changes helped reduce the spread of dangerous bacteria and are still fundamental in managing cystic fibrosis today. In summary, early infection control involved using mist tents that could spread bacteria, relying on broad antibiotics with limited success, and physiotherapy methods that focused on mucus removal but not infection prevention. It was only in the 1980s that the understanding of bacterial transmission improved, leading to patient separation and better hygiene practices. These developments have played a crucial role in improving health outcomes for people with cystic fibrosis by reducing the risk of dangerous infections. Always remember to consult healthcare professionals for personalized advice and care.